So this is multiple evanescent white dot syndrome, which is abbreviated as MEWDS. Now the first thing is, whenever we look at a white dot syndrome, we need to identify the size of the dots, because all of them present to us with flecks and dots. So it's a little hard for us to just look at those dots alone and make a diagnosis. So we use two things. One is we look at the size of the dots. Second, we look for associated features. Now, if you do this in a systematic manner, look at the dots and look at associated features, you will understand that each of them has something very, very typical. And because it has something very typical, you can actually identify it a lot easier than we actually believe. So the white dots in multiple evanescent white dot syndrome are characteristically about 100 to 200 microns, which is actually not a very large white dot compared to some other conditions which we'll be seeing eventually. And these people have what you call a foveal granularity, or a wreath-like appearance, where you can see these small whitish areas. These are the white dots, but you can have a foveal granular appearance. And another classical feature in these patients is the afferent pupillary defect. Now this occurs because there is a predisposition for the involvement of the optic nerve head, or you can see a slight optic nerve head edema, and sometimes this can even be confused with an optic neuritis, because these patients can have an afferent pupillary defect with a slightly hazy optic disc. So you need to pay a lot of attention to look at the surrounding retina. The point I'm trying to drive in here is, if you see a patient with disc edema and an APD, relative afferent pupillary defect, you need to, your examination doesn't stop there. You also have to always look at the surrounding background retina as well. And these patients can have, if you really want to identify visual potential, or more than potential, if you want to know the state of vision in these patients or the retinal function, we do an ERG. After we have kind of narrowed down the diagnosis of MEWDS, you can recommend to do an ERG. The purpose of doing an ERG is to identify the retinal function. Basically, ERG is status of the retinal function when stimulation of light of adequate intensity. So that's your ERG. You can see that the ERG definitely is showing a decrease in function. Now, another important thing is in MEWDS is it is typically unilateral. These patients in MEWDS are unilateral. Most of the white dot syndromes are bilateral, and it has a good prognosis though. So the one good thing about MEWDS is it limits itself. It has a good prognosis even without treatment. So that's your patient. On ancillary testing, you can see that there are these white dots, and these white dots, although you can see them as a very small punctate lesions, later there is leakage around the lesion. The second white dot is acute posterior multifocal placoid pigment epitheliopathy. So what is all this? As the name indicates, it's a placoid pigment epitheliopathy, and it's multifocal in nature, and the presentation is acute. So you've derived everything from just that name. When you say acute, you're talking about a sudden loss of vision, and the patient can have, it's of course a posterior uveitis, and it's multifocal. The patient will show multiple yellow-white flat inflammatory lesions. So that's why you call it a plaque. When you say plaque, you mean a flat lesion. When you say acute, you're talking about sudden loss of vision. So these are the lesions that you're seeing here. You can see that these lesions are definitely larger than your previous slide where you saw MEWDS small punctate lesions. These acute lesions can cause decreased vision. That's the thing. In these patients, they will present to us with a decreased vision. Usually it starts in one eye, it is asymmetric, the other eye can get involved as well, and it can affect the macular lesion. So the patients can have kind of a disturbing decrease in vision, and it predominantly affects the retinal pigment epithelium and the choriocapillaries. There is atrophy and RPE scarring. It can be recurrent, so it can have atrophy and scarring with attacks. You can have new lesions which keep, presenting up to 3 weeks. So again, in the previous slide in MEWDS, we need to know that evanescent. So these lesions will appear and they disappear and new lesions come. That's why it's called evanescent. So again, we need to know that most of the white dot syndromes, you can derive a lot from the name. It's called evanescent for a reason, because the lesions appear and when they disappear, new lesions appear. Whereas APMPP also, the new lesions can keep appearing up to 3 weeks. And a very important question that we may have to ask the patient is the history of a viral prodrome. Several patients present with a previous flu-like illness. They will actually give a history of a flu-like illness in the past, and many of them are also associated with cerebral vasculitis. We need to monitor the patient to look for choroidal neovascular membranes. Management of these patients, it's not really, although some people describe it to be a self-limiting course, when the patient has decreased vision, we definitely may need to address that, especially if it's very severe, with corticosteroids.